Now, it is really important for us to understand different midfoot Charcot deformity patterns in relation to the surgical correction principle. So by and large, there are three patterns of midfoot deformities we normally see. The rocker bottom forefoot abduction pattern. The rocker bottom can involve just the medial column or both medial and lateral columns. The forefoot goes into abduction in that pattern. A different pattern is a dorsal subluxation or dislocation type. And the third one is the forefoot adduction pattern. The forefoot adduction pattern is much less common, and that is due to the failure of the lateral column. But if you look at the frequency of these, the pattern 1 and 2 are the commonest. So let's go through the deforming forces that operate in these deformities. If you look at the rocker bottom forefoot abduction type, the disease initially starts in the midfoot that results in collapse of the medial column as the disease process starts in the medial column of the midfoot, and that lengthens the medial column, pushing the forefoot into abduction, and as a result, the resultant forces of the pull of the musculotendinous units also exaggerate the deformity in that plane. But if you look at the sagittal plane, as the midfoot collapses in the medial column, that drives the hindfoot into equinus, and also the tendoachilles gastrosoleus complex will pull that segment, whereas the tibialis anterior will pull the anterior segment, exaggerating the deformity. If you look at the subluxation dislocation pattern, here the disease processes through and through the midfoot, so that results in overlapping due to subluxation and dislocation breakage of the midfoot, and that results in significant shortening of all soft tissues, and the resultant deforming forces here are the tibialis anterior pulling dorsally, whereas the gastrosoleus complex again pulling the heel unit dorsally. So it's critical that we understand and address this soft tissue imbalance. Here, there is clear equinus component in the hindfoot, as the calcaneal pitch is abnormal, even though the deformity is in the midfoot, because it is the midfoot-driven hindfoot deformity. Here, we need to correct the soft tissue contraction of the Achilles tendinous complex through percutaneous triple hemisection tenotomy of the tender Achilles to improve the calcaneal pitch, and then by performing the midfoot osteotomies, you can correct the whole foot deformity. One must also be familiar with the soft tissue imbalance in the sagittal plane. Particularly the hindfoot goes into varus due to tight and contracted tibialis posterior, and if there is associated dorsiflexion component as well, then tibialis anterior as well in such situation, and those need to be corrected before. So the soft tissue balancing should be achieved before you do the bone correction, and depending on the residual deformity, one can plan the wedge resections to correct the bone deformity. Here the forefoot is in valgus. This is a uniplanar deformity, so by performing a medially based wedge resection using straight wedge cuts as shown in this picture, or you can use a curved wedge cut as well, and we tend to use this particular technique more often. And the key thing is, if it is a uniplanar deformity, if the lateral column is not involved, it is important to keep the lateral cortex of the cuboid intact, so that the apex of your wedge resection is within the mid-substance of the cuboid. And I will tell you the reason why. But I would like to remind you that it's really important that the dissection is not extended beyond that Lisfranc ligament zone, because the dorsalis pedis artery dips down on the plantar side to form the plantar arch. So we don't want to damage that. So you mark the wedge resection areas based on your surgical planning and image intensifier picture. Do the wedge resection, and here you make sure that the lateral cortex of the cuboid is left intact, and through nice gentle plastic deformation correction of the deformity by keeping the lateral cortex intact, you can achieve good bone apposition nice deformity correction, and apply tension band plating on the medial side. So I think it's important to discuss about the fixation principles we use in Charcot foot reconstructions. Samarco presented and published this paper in 2010, stating that one should go for a long segment and durable fixation during Charcot foot reconstruction, and it's absolutely critical that this principle is followed. And this was achieved in those days using long cannulated threaded screws, headed screws, and that can potentially cause damage to the metatarsal heads. And these have been modified since then. So the most accepted current principle of this super construct fixation is a durable, long segment, rigid fixation with optimal bone opposition, as we have also published our experience based on the importance of that principle. So applying that principle, let's go through a few case examples. This is an example of abduction rocker deformity. The lateral column of the midfoot is intact. You can see the calcaneal pitch is reduced markedly. There's a large plantar exostosis of the medial column. So first correct the hindfoot by correcting by releasing the tight tendoachilles. Then you regain your calcaneal pitch, and here large plantar exostosis was excised. Joint medial based wedge resections were done. The lateral column is intact, so there was no need to breach the lateral cortex of the cuboid. So correct the deformity, and on this occasion a plantar plate was applied because the fixation did not require extension into the talonavicular joint, and also the main deforming forces are on the plantar side. And this was done 9 years ago. The patient is still very mobile. A different example, a bit more complex, of subluxation type with long-standing plantar bone prominence that was managed with debridement and same stage reconstruction, as the bone biopsies specimens done prior to the procedure revealed no infection. So on this occasion, this was managed with using the modern principles of a modern fixation devices, using the same principles here, the beams and a locking plate. Beams are the most secure and reproducible fixation devices for midfoot Charcot reconstruction, because beams alone sometimes cannot provide adequate rotational stability. In that situation, additional locking plate is also required. And I would like to emphasize that all joints intended for fusion have to be thoroughly prepared. So a bit more complex presentations, combination of hindfoot plus midfoot reconstruction. 1/3 of our procedures involved combined midfoot and hindfoot reconstructions. In this particular case example, marked hindfoot deformity, marked midfoot deformity with recurrent ulcerations and previous reamputations. So we're not going to discuss about the infection part in this particular talk, but this case was managed as a one-stage procedure because bone biopsies and targeted antibiotics were provided prior to surgery. So initial hindfoot correction followed by a midfoot osteotomy and fixation using a long segment rigid fixation and optimal bone opposition principle. A different example, in this patient, the previous midfoot Charcot that got infected and eventually reconstructed, that failed, got infected again, and referred to us for a limb salvage procedure. So here there is active osteomyelitis going on, so all of that infected bone has to be excised. On this occasion, I did midfoot osteotomy at this stage to decompress the soft tissues to provide a better healing response, and with local antibiotic eluting calcium sulfate preparation applied as well to eradicate that infection. So after about 6 to 8 weeks, the second stage procedure was done using internal fixation, again at this the same principles we discussed earlier. And we had a large group of such presentations using these principles with very good results. So just to finish off, out of 127 midfoot, hindfoot, and combined midfoot and hindfoot reconstructions we have done in our institute. Very high ASA grade, and quite significant portion of these patients were recommended a BKA from the referring hospital, and just 20% of these had active infection requiring a 2-stage reconstruction. So the outcomes so far are pretty good. The limb salvage has been achieved in 100% of patients. 89% of feet had full bone fusion, which is the aim to achieve in all patients. 82% are ambulatory footwear, but metalwork failure, breakage of screws and plates is high in those group of patients that are treated with internal fixation, but that doesn't seem to affect their functional outcome. So that gives you a flavor on the kind of midfoot Charcot reconstruction program we have, and we are happy to take any questions and during case discussions as well. Thank you very much.